Okay. So before moving on, who all wants to participate in answering the questions? You can raise your hands. So I will ask only them and not disturb everyone. I think Vandana will answer. Anybody else wants to participate? Just you try to answer so that you remember, even if we do wrong, no, you will remember that I made this wrong and will learn. Okay. Dr. Shivam, Dr. Sai Shivshankar, anybody interested to participate? Okay. So then, Dr. Vandana,
Yes, sir.
how many questions you are interested in participating?
Yeah, I'll try.
Okay, so maybe in between I will keep asking. Any? Okay. Uh, Devang, Devang, Rathod has raised hand.
Devang, sir. Devang.
Devang. So Devang and Dr. Vandana, you both can practice. And meanwhile, anybody have any doubts anytime, you can unmute and ask the doubts because full paper is like almost 70 questions. So if we keep discussing, it will go definitely more than 2 hours. So anytime, any difficulties, you can stop me. Otherwise, we'll keep moving on with the questions. Okay. 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 So I will read the question and Dr. Vandana and
Yes.
Dr. Devang can alternatively tell the answers. Okay. So here is a 7-month-old boy and there is developmental delay and he was born at term, uncomplicated. 7-month-old, he sits steadily without support. He transfers a toy between his hands. When offered a raisin, he attempts to pick it up using pincer grasp, maybe. And his mother comments that for the past several weeks, he seems to reach for toys almost exclusively with his right hand. So, Dr. Vandana, which of the following findings should prompt the further investigation?
Right-handed preference. Hand preference doesn't come at 7 months.
Okay,
So it
so
has come
should
early
be
means there is something
that
wrong
should
with
be
him.
the alarming part, no? Okay.
Yeah.
So right-sided hand preference. So hand preference is not normally established until 18 months. So 18
Mhm.
months is the cutoff. So hand preference before 18 months is considered abnormal, which means that the other side is weak, probably hemiplegic, cerebral palsy, sort of. So that is an important point to remember. Okay. Okay. So Dr. Devang, a 9-year-old boy with a severe atopic eczema attends a dermatology review. His eczema predominantly affects his face and eyelids. Repeated courses of topical corticosteroid. His parents are worried about skin thinning and ask for a long-term, safer treatment option. So, what options is possible?
The most possible and most suitable options would be tacrolimus 0.03%, but we should take care about the age of the child as if the topical tacrolimus cannot be used less than 2 years of the age. So here the child's age is 9 years, so it would be better option to go with
Okay, very good.
tacrolimus.
And almost it's clear cut, no? So, others are all steroids already. Oral, we don't go for. So, I think what you're saying is right. So, tacrolimus, it's a topical calcineurin inhibitor that acts as a steroid sparing agent and is particularly useful on the face and the eyelids. A prolonged corticosteroid causes skin atrophy. So, what are all the options in illustrated textbook is written is you start with mildly potent corticosteroid. Mildly potent will be 1% hydrocortisone ointment, 1% hydrocortisone. And in children over 2 years, short-term topical, as Dr. Devang said, no. So more than 2 years, short-term topical use of tacrolimus ointment or pimecrolimus cream may be indicated. Okay, so it's more than 2 years, right?
Any side effects of tacrolimus?
Topical.
Why it should not be used under 2?
Okay, I will check it, doctor. Less than 2 years. Right. I'll post it in the group, doctor.
Okay.
And okay, this one. A 15-year-old for Dr. Vandana, competitive swimmer,
Yeah.
attends a sports medical assessment before a regional championship. Examination reveals several plantar warts on the sole of his foot. Otherwise, he is asymptomatic. And his coach asks whether he should be excluded from swimming until treatment is complete. So what option?
No, we normally don't exclude them from swimming. We
So
cover the lesions with waterproof plaster while swimming.
Okay, very good. So plantar warts are not a contraindication to swimming. So the lesion should be covered to reduce the transmission in communal swimming areas. So in illustrated guide, what is given in plantar wart is most disappear spontaneously over a few months or years, and treatment is indicated only if the lesions are painful or a cosmetic problem. Okay, and what to apply? It will be salicylic acid and lactic acid paint or glutaraldehyde lotion can be used. Cryotherapy with liquid nitrogen is also an effective treatment. So you can remember these options. Sometimes they will ask you what treatment option, so you should be ready with
Yeah.
these options. Okay. Okay. So Dr. Deva, anybody else wants to participate, ma, so that you will be more interested? Just keep trying. You can raise your hands. I will ask you. Just participation only. Don't worry about making mistakes.
Okay.
Yeah, Dr. Imran, I will note down. We will alternate. Dr. Trishali, okay, very good. I think all are now better. Very good. Dr. Amardeep, Dr. Trishali, Dr. Imran, Dr. Vandana, Dr. Deva. Anybody else interested? I will note down. Okay, so I think we will move on with I missed anybody, you can just tell, no issues. Dr. Imran,
Yeah.
this is for you. 16-year-old boy is referred to the endocrine clinic because of delayed puberty. He is taller than most of his peers and is distressed by the enlargement of his breast. Examination demonstrates sparse facial hair, small firm testes, and mild gynecomastia. So which diagnosis best explains these findings?
It's a Klinefelter syndrome.
Klinefelter syndrome. And why not it is just a hypogonadotrophic hypogonadism?
Because the tall height is there in it, so it goes in distinct favor. And a gynecomastia, boy with a gynecomastia, tall stature, they have not mentioned about his this thing, testes or anything, but delayed puberty, facial small, small form testes is also there. So that fits in Klinefelter syndrome.
Yeah. So hypogonadotrophic hypogonadism also can be, they will be taller. They can also have some gynecomastia. It's all there. But the testis, it will be soft in hypogonadotrophic hypogonadism. But this firm testis is part of this hypergonadotrophic hypogonadism, where FSH, LH will keep on circulating, but the testis will be small and firm. Okay, so we can accept it. So Klinefelter, so 47XXY. And in illustrated textbook, these are the points. Most common presentation, infertility, hypogonadism, pubertal development may appear normal. So they might go into something like arrest in progression also. It's not like always delayed puberty. They can have initially the puberty kicks in and they stop progressing. And gynecomastia is the characteristic feature. Tall stature and intelligence is usually in the normal range. So kind of they will be almost, they look similar only, except for some amount of tall stature and gynecomastia. Small testis is the key distinguishing feature of Klinefelter syndrome. Yes, Dr. Devang, anything you want to add?
Sir, what will be the feature of hypogonadotrophic hypogonadism? And the Klinefelter is called as hypergonadotrophic hypogonadism.
Yeah, it is hypergonadotrophic hypogonadism. It's just like the Turner syndrome equivalent. In the girls, you have Turner syndrome, where again it is hypergonadotrophic hypogonadism. And for hypogonadotrophic hypogonadism, it will be almost similar, doctor, except the testis will be very soft and plus other features. Sometimes it might be a pan-hypopituitarism where the other growth hormone, thyroid, and also other things might be affected. It is an isolated ask history of very common will be for your level will be the anosmia. So if anosmia is there, hypogonadotrophic hypogonadism, then Kalman syndrome will be in your diagnosis. Okay. Okay, doctor. So next, Dr. Trishali, you're there. Dr. Trishali. Okay, Dr. Amardeep.
Yes, I'm here. Good
Yeah.
evening, doctor.
Good evening. So your name is?
Amardeep. I'm Amardeep.
Okay, okay. So here is doctor. A 6-year-old child presenting with persistent cough lasting 3 weeks. Parents report episodes of severe coughing followed by vomiting. Examination revealed petechiae over the face and upper chest, but no other bruising. Platelet count is normal. So what is the most likely diagnosis?
Yeah. So the choice is pertussis infection. It has the features of pertussis like there is a cough which is for 3 weeks. There is post-tussive vomiting, and the cough is severe enough to cause petechiae over face and the chest. Platelet count is normal, so we can rule out ITP, leukemia, and since and meningococcal disease also, I mean, the features don't fit with that. So the answer would be pertussis infection.
Okay, very good, doctor. Very good. So in the illustrated book, the final summary, I think we all know Bordetella pertussis, but most important is in infants, it might not be the characteristic, the pertussoid cough. More often they can present with apnea rather than oof. So that is an important point. And in UK, they are more interested with pertussis. I think it's common there because of the waning immunity, and the vaccine is not that efficacious. So pertussis is still common in the babies there, and it is suggested by the marker lymphocytosis. I think that you should be aware of, and confirmed by the PCR from per nasal swab, and be ready with giving macrolides, erythromycin. Yeah. So facial petechiae in a coughing child suggest pertussis. Dr. Amardeep, actually, one more question they, even in AKP also they ask. Suppose a child has palatal petechiae. So what's in your DD?
In case of palatal petechiae, then we should think of uh, uh, infectious mononucleosis.
Yeah,
Probably.
yeah, very good. So infectious Epstein-Barr. So they have given a picture of palatal petechiae. They were asking what is the cause. So you should be aware of the Epstein-Barr virus. Yeah, good. Okay. So Dr. Devang, 2-year-old boy presented with lethargy, pallor, constipation. He drinks approximately a good amount of cow's milk, limited solid diet.